Good evening all, and thanks AIOC for this opportunity. Basically, it's a comparative study of using the PFCL without PFCL in case of giant retinal tears and their outcome. Boss, yeah. So we know by definition at least for 3 clock hours or 90 degrees along with PVD, if the tear is there, we call it a giant tear, and the incidence is around 0.05% and it varies also. So there are various causes. It can be idiopathic from trauma to high myopia or following laser or cryotherapy. Usually, previously they have been doing buccal. Now, pars plana vitrectomy is the mainstay of surgical management in these cases. And despite the invention of newer techniques, the reattachment rate is not very high, and it ranges anywhere between 48% to say 100%. I mean, the largest series it's only 64%. So many of these go for re-RD either with the silicone oil or after the removal of the silicone oil. So basically, we want to compare the efficacy of two-stage surgery, in which we use PFCL as a short-term tamponade replaced with silicone oil, in comparison with the conventional single-stage surgery following long-term. So it's basically a retrospective study with the 74 eyes of 68 patients over a period of 5 years' time, and these are the inclusion criteria, and these are the baseline data which we measured. So in the first stage of surgery, the patient underwent the vitrectomy, and after the complete vitrectomy, the PFCL is almost filled up to 60 to 80%, and it is topped up with silicone oil, and the patient is kept in supine position for 5 to 7 days, and later on we'll take the patient for second stage where we replace the PFCL with fluid air exchange, and then we do the lasers in the second stage and do silicone oil filling. And without this PFCL is the conventional surgery where we fill the silicone oil cavity, vitreous cavity with silicone oil after the complete vitrectomy and endo laser in the single stage surgery. So these are the pictures after doing the base shaving. In cases if it is needed, we peel the ILM and then we fill it with PFCL topped up with silicone oil so that there is no movement of the PFCL into the EC. In the other arm, we'll just inject. So these are the statistical methods. And we have not come across any serious adverse event because of the filling of the eyeball with the PFCL in that 5 to 7 days time. And if you see, the baseline is almost similar, but the initial vision in the PFCL group is slightly worse because we had a lot of PVR cases and the total RD cases in that. And this is the axial length. Most of these cases were emmetropic and very few were myopic. And mostly it is pseudophakic in both the groups. And there were choroidal detachment in 11% of the cases. The advantage of using PFCL in these cases is within 24 hours of retaining the PFCL in the eye, the CDs completely disappear, and thereby it is helpful for us to do the endo laser during the second surgery. And almost 13 cases had 13% had PVR changes in both the groups. When you see the final reattachment rate, it's close to 90% in the first group, compared to 18 out of 22, almost similar in the second group. But when it comes to the question of vision, the improvement is very marginal in the first group where we use PFCL, because the initial vision also was poor in that case. And PFCL was removed in most of the cases except for 7 in the first group, because we retained as there was inferior retinal detachment. So coming to the discussion, when we compare this short-term PP with the single-stage vitrectomy, the patients who underwent short-term PFCL tamponade achieved a better anatomical as well as the functional outcome compared to only silicone oil group, and the redetachment is much lesser in case of the PFCL group. So compared to our study, it is almost similar as far as the demography is concerned, the age group also. And we had almost 13.5% of the cases with PVR, and almost all of them settled in this case. So although PFCL is an excellent tool for intraoperative, very few people are using it for the short term or the intermediate tamponading agent. So it was first used as the tamponading agent for GRTs long time ago. And these are the studies which give very good results while using PFCL for the short term tamponade for the reattachment. Usually there is not much of toxicity which we have seen. Okay. So the basic limitation of the study, it's basically retrospective. Maybe an RCT prospective will be giving a very unbiased result for this particular trial. And the visual acuity in the cluster A where we use PFCL was very bad, in the sense comparatively lower in the initial phase. That's why the final outcome of 6/60 was lesser in the first group, and we need a larger sample size. But however, in conclusion, a short-term tamponade of PFCL with silicone oil and GRT-RD gives a excellent reattachment rate. In fact, the high specific gravity of PFCL helps us in flattening the retina, so that when we do the laser during the second stage, it takes up very well. So we have never seen any slippage or any macular fold happening due to this, and there is no need for any scleral buckle in these cases. And with this, it is easy for us to operate even PVR C3 and above also with PFCL as a tamponade. Thank you.
Since you exhausted time, probably we will not go for questions. But the only suggestion I would say that you need to analyze the cellular level damage, which is reported long ago. That over 2 weeks' time, if you retain PFCL, there can be retinal neurophotoreceptor, mainly neurosensory layer degeneration. So you need to somehow rule out that.
Yeah, up to 3 weeks it's not a problem, sir. And second thing, oxygenation is better with PFCL than with silicone oil.
Yeah. Those aspects you need to consider.
Naresh, one more question. Sir, based on your experience now, do you think that short-term PFCL tamponade may be better in all retinal detachments?
In fact, I'll say yes. For all GRTs, default we go
all retinal detachments.
Yes, for retinal detachment also. In fact, in the second stage, we remove the PFCL. We don't fill it with silicone oil. We instead fill it with gas.
Chintan